So you start to see beta cell destruction after the autoimmune process starts to affect them. This is a gradual decline, or rapid gradual decline in beta cells. And then once you reach that 80 to 90% of beta cell destruction, that's when we move into clinical onset of type 1 diabetes. Prior to this, you might start to see a few symptoms, which we talked about as some polydipsia, polyuria, some glucoseuria, and then as we move into diabetes, we really start to see that insulin deficiency and requirement for treatment. Type 2 diabetes has a slightly different pathophysiology and much more slower progression. So it's characterized by impaired insulin secretion and resistance to insulin action. And so, contrary to type 1, where we have an absolute insulin deficiency, with type 2 we have more of a burnout type syndrome, where the beta cells are still potentially secreting insulin, but potentially not secreting insulin to the degree that is needed to compensate for the blood glucose, and the insulin that is secreted is having trouble being used appropriately in the body due to resistance to that insulin. So glucose utilization by the tissues is impaired. The production of hepatic glucose and free fatty acids are increased. The excess glucose is then accumulating in the blood without anywhere to go, and the pancreas is constantly stimulated to produce more insulin to overcome a resistance. So, to think about that, we have this constant elevation of blood glucose, which can be due to a number of different causes, which we will talk about in a minute. This constant elevation of blood glucose results in increased beta cell function in the pancreas, which results in a constant increase in insulin levels. Due to this constant increase in insulin levels, your insulin receptors begin to downregulate, and so because there's so much insulin around, your body kind of compensates with that by decreasing how much insulin receptors there are for it to activate with the hopes of decreasing the insulin production, which will lead to insulin resistance. Those receptors are not as many, there's not as many of them, and so we don't get the same insulin action as we would in somebody that does not have this constant high insulin level increase. And so because we're getting to a limit of insulin resistance, we end back in this cycle of constant elevation of blood glucose, and your beta cells are continuously trying to produce more insulin because the insulin that it's producing is not producing the same effect that it had in the past, and so we get this constant beta cell production of insulin that eventually will tire out the pancreas and prevent it from providing us adequate insulin to deal with the elevated blood glucose levels. So potential etiologies of the development of type 2 diabetes, or the etiology of this beta cell destruction and reduction of functioning, falls from a number of different mechanisms. This insulin resistance that we discussed, glucose toxicity, so having excess glucose in the bloodstream, lipotoxicity, age, increased age as we produce genetics, and deficiency in ingredient. So what is insulin resistance? So we talked about it a little bit just now, but to go into a little bit more detail, the body produces insulin but is unable to use it effectively. So the beta cells are producing insulin, but the insulin that it's producing is not having quite the same effect that it used to in reducing its blood sugar, and so this prompts the body to promote more insulin. So likely areas of resistance include the muscle, the liver, and the adipocytes. So higher levels of insulin are required to reach euglycemia and lead to overworked beta cells. And this production of insulin and overworking of the beta cells will continue even after diabetes is diagnosed and treatment has begun, which is why you'll see when you get to the treatment, the patients will often require increased increasing amounts of diabetes medications over time in order to control the blood sugars, because even though once it's diagnosed we cannot halt this process, we can only find ways to essentially slow it down. And this is to highlight where insulin resistance and beta cell function kind of interplay. So you have your diabetes, genes, inflammation, chronic hyperglycemia, free fatty acids, other things that are going to affect beta cell function and insulin resistance. Constant insulin resistance is going to kind of back loop to beta cell function, and constant emphasis on the pancreas to produce more insulin from its beta cells can result in death of those beta cells and burnout of those beta cells, which is going to result in eventually less insulin. And because the insulin that's produced is not as effective, we lead to this chronic increase of hyperglycemia, a vicious cycle. So the insulin resistance is going to prevent the insulin from working where it typically does. So it's preventing insulin normally allows for free fatty acid production from via lipolysis. It would normally prevent that process by allowing the tissues to hold on to glucose versus allowing them to be released. Insulin would normally decrease glucose production from the liver and promote storage of glycogen, and it would normally promote glucose uptake. So insulin resistance is going to work by reducing those. So reducing the liver's ability to decrease its own glucose production, decrease its ability of the tissues to hold on to their glucose, which results in production of further glucose and further production of ketones, because those amino acids from the tissues are being converted into ketones in the liver. There are also some drugs that impact blood glucose. So when you're looking at a patient that is presenting with symptoms of increased blood glucose, or you are treating a patient with a blood glucose that's elevated and they're taking their medications as prescribed, you want to look at their other medications to see if there's other factors that may be resulting in an increased blood glucose or decreased blood glucose even. So there's a number of different agents here. One that I'd specifically like to highlight is glucocorticoids or steroids. They have a very significant impact on your blood glucose, especially in patients that have chronic need for anti-inflammatory therapy. And so this will have a direct impact on their blood glucose control. Others include antipsychotics, as you discussed in neuropsych. Your second-generation antipsychotics have significant metabolic side effects, and so very many patients who are on antipsychotics should be monitored for the development of diabetes due to the increase of blood glucose that results. So symptoms of type 2 diabetes. So what are we going to see in someone that is presenting with kind of a chronic high blood sugar? So similar to those symptoms we talked about with type 1, we start to see the polydipsia and polyuria, so frequent urination and the compensatory thirst that comes with that. We may also see hunger, blurred vision, changes in vision from that increase in chronic glucose within the eye, tiredness or fatigue, as well as nausea from chronic high glucose. The three common symptoms that you'll commonly hear of is the 3 Ps. So the polyuria, the polydipsia, and polyphagia. And so those 3 that we talked about is the extreme thirst, or the polydipsia, the frequent urination, or the polyuria, and the polyphagia, which is kind of the extreme hunger. And so I have hypoglycemia here, which you'll talk a lot more with Dr. Baker when you start to talk about treatment. But I did just want to point out that there are similarities in terms of the symptoms that are experienced, and so it's often very difficult for patients to differentiate hypoglycemia from their normal symptoms. So as you can see, blurred vision, a symptom of hyperglycemia, also a symptom of hypoglycemia. Extreme hunger, a symptom of hyperglycemia, also a symptom of hypoglycemia. And normally the mechanism in hypoglycemia is that their blood sugar is low, so their body is telling them they need to intake something. Nausea is also a sign of hyperglycemia, as well as sweaty and dizziness is a symptom of hypoglycemia, which can feel very much like nausea. And so these symptoms are kind of gray between both elevated hyperglycemia and low hypoglycemia. So it takes a lot of training and education and discussion about what these feel like in each individual patient to help them identify when their blood sugar might be low. And this is definitely going to be an important piece when you're talking about different therapies to treat type 2 diabetes, specifically insulin therapy. So clinical presentation and what the differences are between type 1 and type 2 diabetes in order to sum up. So we didn't talk much about it, but usually the age of onset varies significantly between type 1 and type 2. So type 1, you may have been heard of in the past as juvenile diabetes, is normally diagnosed in childhood. And if you think about the mechanisms of how type 1 diabetes progresses, it's an autoimmune disorder that takes place with the insult of environmental factors and or predisposed genetic conditions, and so very often this is going to present itself in the childhood years. Versus type 2 diabetes is more of a beta cell decrease in function and insulin sensitivity issue, which is going to gradually onset. And so onset usually is not diagnosed or noticed until over the age of 30. So we notice the speed is different between the two in terms of progression. Type 1 is more of an abrupt change in insulin availability and pancreatic cell death versus a gradual decline in function with type 2. Family history is often not associated in type 1 diabetes, although if you do have a family relative that is type 1, often they will test because you can test for those genetic autoimmune markers, but there's not a strong correlation in family history. So if your mom is type 1 diabetic, does not mean that your child will necessarily be type 1. However, in type 2 diabetes, there is a positive family history correlation with our prospective relatives and relatives that are diabetic. We will see a correlation with their offspring later on in life. Body habitus is also another way of identifying type 1 versus type 2, but by no means is this absolute. There are definitely type 1 diabetes patients that, while the common is that they are thin and lean, have this more obese, overweight look to them, as well as type 2 diabetics that have the stigma of being very obese and overweight, and while that is a huge risk factor, there are definitely patients who do not fit that description and may fall on the thin or lean side, but are experiencing type 2 diabetes. We'll talk a little bit later about metabolic syndrome. While this is not a term that is used as often anymore in terms of categorizing characteristics of a patient, so patients that have other risk factors outside of type 2 diabetes for cardiovascular type health, so increase in lipids, increase in blood pressure, obesity, that is more correlated with our type 2 diabetic patients versus our type 1. Our antibodies are present with our type 1 diabetes. There's really no autoimmune type response to our type 2. The presence of ketones is present very commonly in our type 1 diabetes, especially after that 80 to 90% of beta cell destruction. Very uncommon in our type 2 diabetes, except when severely